Well, good evening and a very warm welcome to everybody that has joined us this evening. My goodness, it's a busy night tonight. So it's fabulous to have so many people here. A massive welcome from us at NB Medical and Cancer Research UK. This is the Head and Neck Cancer Clinic brought to you with lots of enthusiastic presenters this evening. It is absolutely fabulous to have you all here. Because we only have an hour, I am going to get started straight away and introduce people firstly. So if you don't know me, then my name is Kate Digby. I am a jobbing GP partner and trainer in a very pretty town called Cirencester in Gloucestershire. I've got a bit of a portfolio spread to my week, so I'm a programme director for our local VTS and clinical director for our local PCN. And I've been working with NB Medical for many years now, delivering our sort of mainstream courses, and I have particular interest in the cancer side of things. So the cancer course and all of these cancer clinics brought to you with Cancer Research UK are my babies, so to speak. So I'm going to be doing some of the presenting tonight, but you are very fortunate that you don't have to just listen to me. I'd like to hand over now to my co-presenter this evening and say, good evening, Lance. How are you doing this evening?
I'm doing great, thanks. Thanks, Kate. I'm Lance Saker. I'm also a GP partner. I'm in London. I don't know if I'd call it beautiful, but it's interesting. I also am a CRUK GP for London, and I am the primary care diagnostics lead in London. My interest is in early diagnosis, in diagnostics for cancer. And I'm going to hand you over to Andy.
Thanks, Kate. Hello, everyone. My name's Andy. I'm also a GP. I work in Leicester, which definitely isn't a pretty place for most of the city, I have to say. And I work in inclusion health, so I have lots of interest in health inequalities. I feel very passionate about that, and we're going to cover a little bit of that later on in this talk today. And I work at Leicester Medical School, where I teach a lot of empathy to medical students, communication skills, all those things that you need to be a really good GP, and I'm sure a lot of you have them. I'm doing the Q&A this evening. So if you have any questions, any comments, any suggestions that arise as they're going through the talk today, just pop them in the Q&A box there. I'll do my best to answer them. There's a load of people on tonight, and it's a really short presentation. So I apologise in advance if I don't get to your question, but just post them up there. They're all anonymous, so there's no such thing as a silly question. Pop them in there, and Kate will give me a chance to share some of those as we go through the evening. But just hope to speak to you later. Thanks.
So what are we going to cover this evening? Well, we're going to start by having a look at the latest evidence around head and neck cancers, and specifically look at those statistics that tell us about incidence and survival. There are some inequalities in presentation when it comes to head and neck cancers, like we see in many other cancers as well. So we'll have a little think about those, and perhaps some of the barriers that exist when it comes to trying to achieve an earlier diagnosis. We're going to have a think about risk factors. There are some clear risk factors when it comes to head and neck cancers, and those risk factors will help us when we consider our role in primary care when it comes to risk factor prevention. I'm then going to hand over to Lance, who's, as he said in his introduction, has got an interest in earlier diagnosis. And he's going to run through the current referral guidelines that we work towards here in the UK, and really talk about those key symptoms that might make us think about the presence of a head or neck cancer when it comes to making a decision on how to manage patients. He's got some brilliant practical advice around the assessment of these patients, and some advice around how to optimise and really refine the referrals that you send, alongside some safety netting considerations. Now, whilst Lance and I are presenting, Andy will be very busy in the background answering all the questions that you may have, so please do keep him busy with any comments or suggestions. Also, if you haven't seen it yet, down at the bottom of your screens, you'll see that there's a resource tab. And within that, we've put plenty of resources that we think will be super helpful to you as you go about your day-to-day business in primary care. Lots of cancer research resources to share with you as well. So when it comes to thinking about head and neck cancer, what are we actually talking about? Because, of course, there's quite a lot that goes on from our shoulders up. We've got nasal and paranasal sinus cancer. We've got mouth and oropharyngeal cancer, and that includes tonsillar cancer. There's laryngeal cancer, salivary gland cancer, nasopharyngeal cancer, and indeed throat cancer. There's plenty of areas in the head and neck that can unfortunately develop malignancies as life goes on. Now, the most common site for head and neck cancer in the UK is tongue cancer, and that's followed by laryngeal cancer for males and tonsillar cancer for females. And it's interesting to note that there has been an increasing trend in the diagnosis of oropharyngeal cancers in recent years. Indeed, over the last 10 years, oropharyngeal cancer cases have increased by 42% in the UK. Now, that can't just be down to a better diagnostic process for clinicians, GPs, and secondary care alike. There must be some other developments as well, and we're going to think a little bit about those when we think about risk factors. One of the really interesting areas, I think, is the role that having HPV infection plays when it comes to the risk of developing oropharyngeal cancer. Let's think a little bit about stage at diagnosis and the impact that has on survival. Because like the majority of other cancers, if you can diagnose the cancer at an earlier stage, the survival is improved. And there is a significant survival gap in head and neck cancers. So if you look at the data taken from Wales, if you are diagnosed at stage 1, you have a 96% 5-year survival. That drops to just 46% if you are diagnosed at stage 4. Similar pattern is seen elsewhere in the UK. In fact, in Northern Ireland, that gap is bigger. 83% 5-year survival at stage 1, just 28% at stage 4. So you can see how if we can improve the stage at which patients are being diagnosed, we can actually have a very positive impact on survival statistics. Now, the sad thing is that at present for head and neck cancers, a significant proportion of them are diagnosed at that later stage, either stage 3 or stage 4, when the cancer is no longer localised, when the chance of curative treatment is no longer a likely outcome. And when you look at the sort of stage at which cancers are diagnosed, certainly within England, 54% of oral cavity cancers are diagnosed at stage 3 or 4, 86% of oropharyngeal cancers, and 49% of laryngeal cancers, all diagnosed at that later stage of stage 3 or stage 4. Wales and Northern Ireland have a similar percentage of late-stage diagnoses for head and neck cancers, and in fact in Scotland, stage 4 is the most common stage at diagnosis. Now, one question that, just to think a little bit about poll questions for a second, is in England, what percentage of head and neck cancers are diagnosed via an urgent route? Now, when I talk about an urgent route, I'm really talking about whether or not these patients were sent down an urgent suspected cancer referral route, or what we call in England, used to call in England, the 2-week referral route, or whether they are diagnosed having had a more routine entry into secondary care diagnostic processes. What do you think about that? Oh, that's great. Thank you so much, everyone, for clicking the answers. Let's have a look and see what the mood of the nation was. So there you go. Front runner was 23%, followed up by 54% was the second best. Okay, so actually those that said 54%, you get the gold star on that one. Well done. Really what we're talking about here is the routes to diagnosis, because most patients are diagnosed following a referral from their GP. And in fact, if you look at the data that we have for England, going back to 2019 now, 54% of all head and neck cancers were diagnosed following an urgent suspected cancer referral. Just 22% were diagnosed following a routine referral, and 8% presented as an emergency. We see fairly similar data when you look at the statistics coming out of Northern Ireland also for 2019. Majority are diagnosed following a red flag referral. Now, we know just from other cancer groups that if patients present as an emergency, they tend to do less well from a survival point of view. Their outcomes tend to be worse. And some patient groups have a much higher rate of emergency presentation than others. In the UK, those include those with higher deprivation scores or lower years of education, those from ethnic minority groups, those of an older age, or those who have multiple comorbidities. And in fact, men are more likely to present as an emergency compared to females. Just thinking a little bit about deprivation and late stage diagnosis, you can see that from this graph that you are more likely to have a late stage diagnosis of head and neck cancer if you happen to belong to the most deprived quintile compared to the least deprived quintile, showing that there is really a health inequality that exists when it comes to head and neck cancers. So here's another question for you just to think about. In the UK, what percentage of head and neck cancers are thought to be preventable? When I talk about preventable cancers, I'm talking about cancers that could be avoided if particular risk factors were avoided as well. So how much do those modifiable risk factors impact on the risk of head and neck cancer? Do you think it's between 5 and 10%, between 20 and 30%, between 33 and 41%, or between 46 and 88%? Have a look and see what you reckon. Okay, so yeah, most people are going down that sort of the big chunky one, the 46 to 88% of head and neck cancers are preventable. That's quite a significant proportion, I'm sure you would agree. But you're absolutely right. So really what we're thinking about here is those risks of leading to sort of an increased likelihood of developing head and neck cancers. And in the UK, it's thought that between 46 and 88% of head and neck cancers are preventable. Let's just clear off the sort of non-modifiable risk factors to start with. We can't do very much about non-modifiable risk factors, though having an awareness of what they are is quite helpful when it comes to working in primary care, as it increases your suspicion that something may be amiss. So, for head and neck cancers, more common as your age increases. They're more common in those who've had a previous cancer or those who have a family history of oral cancer. There's also some genetic changes that can predispose to developing head and neck cancer, and having any duration of immunosuppression can also increase your risk. When it comes to modifiable risk factors, so these are the ones that we can really start to talk to patients about in terms of avoiding those risk factors that may contribute to the likelihood of them developing a malignancy. That includes all tobacco groups. So the obvious ones, cigarettes, cigars and pipe smoking, but also biddy smoking, chewing tobacco or chewing betel quid, exposure to environmental tobacco smoke, that's what we used to call passive smoking, alcohol exposure or drinking excess or greater than recommended levels of alcohol can increase the risk of head and neck cancer. There are some infections that increase your risk as well, and that includes Epstein-Barr virus infection, HPV, we're going to talk about again in a minute, H. pylori infection, and indeed HIV. Radiation exposure, whether that's UV radiation or ionizing radiation, can put your risk up. Having any form of precancerous mouth condition can increase your risk as well. And then there's some occupational exposures to bear in mind. And this, of course, is not it's not a complete list. There are other ones as well. But the main players here are asbestos exposure, exposure to wood dust, formaldehyde, and men or people, not just men, but those that work in the rubber production industry are at increased risk of head and neck cancer. Let's just go back to the big ones there, the main players on that modifiable risk factor list, and that's probably smoking and alcohol when it comes to things that we can really intervene and help patients with. So tobacco use in any form is linked to cancer. Smoking causes 62% of laryngeal cancers, 34% of pharyngeal cancers, 18% of nasopharyngeal cancers, and 15% of oral cavity cancers. They're fairly sort of big numbers, aren't they? And what we do know is that e-cigarettes are far less harmful than smoking or tobacco exposure. So e-cigarettes are certainly something to talk to patients about as an effective smoking cessation tool. We know that in the short term, they're much safer. In the longer term, we can't be quite so certain because we do not have any long-term trial data at present. E-cigarettes just haven't been around for long enough for us to be able to make those judgment calls. Then let's think about alcohol. And alcohol is thought to cause 38% of pharyngeal cancers, 34% of oral cavity cancers, and 22% of laryngeal cancers. And perhaps we don't talk about alcohol levels as much as we could when it comes to dealing with our patients in primary care, but it's certainly worth reminding patients that drinking above the recommended limits for alcohol intake can be harmful to their health for many other reasons. If you want some more resources, if you want some more information on things to share with patients, have a look in the resources tab. Cancer Research UK have put plenty of information together for healthcare professionals to help support them when they're having those conversations with patients about either smoking cessation or reducing alcohol intake. Finally, let's just think about HPV infection for a second, because we're very familiar now with considering HPV infection when it comes to cervical cancer risk. We also know it's associated with anal cancers and other form of genital malignancies. But it is also thought to be associated with 70% of pharyngeal cancers and 1% of oral cavity cancers here in the UK. And it's interesting to note that the incidence of both of these is increasing in men and women. Now, the key take-home message, I think, here is that HPV-positive oropharyngeal cancers may present differently compared to HPV-negative cancers. They typically occur in younger patients, and I guess crucially that smoking and alcohol consumption history may be absent when you're getting information from the patient to ascertain what their risk factors for developing head and neck malignancy may be. So it's worth remembering that, just to kind of increase your level of suspicion if somebody presents with symptoms that may be caused by a head and neck malignancy. Now, the good news for patients is that if they do develop an HPV-positive malignancy, they generally have a better response to treatment and survival is improved compared to those who have an HPV-negative cancer. The other sort of real learning point for me when it comes to thinking about HPV infection avoidance is really the sort of enthusiastic promotion of the HPV vaccine for anybody that may be eligible. So remember that the vaccination programme here in the UK is offered to children aged between 11 and 13, that's both boys and girls, and to men who have sex with men up to the age of 45. There are some other groups of patients who are deemed to be at higher risk of developing HPV infection who may be able to access the vaccine through sexual health clinics. And the vaccine that we're using now is Gardasil 9. That covers 9 high-risk strains of HPV and is thought to be incredibly effective. Bear in mind that we do have some sort of broader availability, certainly for girls under the age of 25. They can still access the vaccine, although the vaccine is less effective as children get older. And boys born after the 1st of September 2006 are also eligible to access the vaccine, though anybody born earlier than 2006, unfortunately, are not eligible. So our role really is to be aware of the eligibility criteria for the HPV vaccine and therefore be able to promote informed consent for our patients and their families. Okay, so that's a little insight into risk factors and the sort of what's going on in the evidence. I'm going to hand over to Andy now and say, Andy, how are you getting on those questions?
Thanks, Kate. Yeah, they come in thick and fast, as they always do, just as when you're about to get me on the on the Q&A. Someone saying here about e-cigarettes. It's a very broad statement, say e-cigarettes are safer. They're safer reducing cancer risk, but actually, anecdotally, they talk about people with lung disease, lung issues when using a lot of e-cigarettes. I think that when they're used as an aid to stop smoking, they're obviously better. But obviously, if someone's not a smoker, then they probably ought not to be using e-cigarettes or starting with those. More questions coming through. What strains of HPV are linked with head and neck cancer? Is it the same as cervical cancer? I actually don't know. I will find that out unless Kate or Lance are able to give me that information. I had a male patient, 37 years old, who was asking for HPV vaccine due to reducing his risk of oropharyngeal cancer. He didn't have the vaccine as a child. I don't think he'd be able to get it unless he was in a high-risk group, like a man having sex with another man, for instance. Are snuff pillows related to increased oropharyngeal cancers? Not a tobacco pouch, but a nicotine pouch with no tobacco in it. I've never heard of those. Has anyone else heard of those? I would think if it's not got tobacco in it, it'd be similar to the e-cigarettes if it's pure nicotine. So that shouldn't be increased with a risk of cancer. I'll Google that whilst Lance is doing his little bit. And then someone asking about immunosuppressant, does that include biologics? I think anything that suppresses your immunity increases your risk of cancer and oropharyngeal cancer. And particularly, I think patients with HIV have high rates of oropharyngeal cancer, and that can be linked to HPV as well. So it may be that they're a bit more susceptible to the HPV effects if you're immunosuppressed as well. Loads more questions coming in. What I'm going to do is I'm going to try and answer these now whilst Lance is talking, because otherwise I'll be here all night answering all these. So I'm going to hand over to you now, Lance, and I shall have a stab at some of these questions while you're talking.
Great, thanks, Andy. So I'm going to talk about how to recognize head and neck cancers. And one of the first things to say is that this is a challenging area. I think there are a number of reasons for that. The first is that the symptoms of head and neck cancers are often the same as some of the most common illnesses that we see in primary care. For instance, upper respiratory tract infections, very non-specific, sore throats, nasal symptoms, etc. And in many cases, our physical findings are not really helpful. They don't really add much to the situation. Obviously, lumps is a completely different thing, but for throat symptoms, very often not. Finally, investigations in primary care often don't help to stratify risk. So you're really making a decision at that point about whether this person needs to be referred to a specialist to have nasolaryngoscopy or some other investigation. So it's really important to be aware of who your high-risk patients are, and it's something I'll come back to and something that Kate has covered very well before. Many patients also do present with advanced disease. Now, this is probably partly biological. Unfortunately, a lot of the cancers develop in very vascular areas in the upper respiratory tract. But access issues are also important here. And some of the key risk factors for head and neck tumors, as we've heard, are themselves associated with poor access, such as smoking, socioeconomic deprivation. Therefore, once again, early recognition and referral of high-risk people, symptomatic high-risk people, understanding who's high risk and safety netting are going to be really key here. So your assessment will include, and this is fairly obvious to most of us, but worth repeating, a good history with timelines being very important. Assessment of their underlying risk, and I put smoking and alcohol, but as Kate has rightly pointed out, there are others as well you should ask about. And finally, your examination. So throat, mouth, ears, neck, lungs, etc. One thing that we sometimes feel uncomfortable about doing as GPs is looking at the mouth. And we are not dentists. We shouldn't be expected to look at the mouth like a dentist, but it is possible to have quite a good look at the mouth with a GPI. And there's an excellent toolkit, which will be available in your pack, called the Oral Cancer Toolkit, that covers GP examination. It's actually being updated, and there'll be a new version available in spring. There are some risk assessment tools. I've mentioned one over here. They're mainly used in specialist settings, so I'm not sure I would recommend using them in your clinical practice, but they are very interesting to look at in terms of showing you who really is at risk and how strikingly greater the risk is in certain people for the same symptoms. So really the most common presenting symptoms, taking the different sites, are laryngeal cancer would be hoarseness, oral cavity would be a lump, and oropharyngeal cancer, a neck lump. And it's important to be aware, as you can see from here, that although these are the commonest symptoms, they by no means cover 100% of people who present with these cancers. So you need to be aware of others as well as combinations of symptoms being a very important thing to look for. So starting with the national guidelines, which really are the basis for how we should assess patients. There are 3 national guidelines. We have the NICE guidelines for England and Wales, the Northern Ireland guidelines, and the Scottish guidelines. And I'm going to take them each in turn. NICE only covers 3 areas, actually. The first is laryngeal cancer with unexplained hoarseness or lump in people over 45, oral cancer with unexplained ulceration or a lump on the lip or oral cavity, and thyroid cancer with an unexplained thyroid lump, which I'll come to later. It's interesting that NICE does not specifically refer to throat cancers, apart from laryngeal, and it's something I'll come on to later, but is covered a little bit more by some of the other guidelines. So if we go on to the Scottish referral guidelines, and these are, I believe, due to be updated in spring, so they may change, but as they currently stand, an urgent referral should be considered in these people here. I won't go through each of them, but worth noting that they are more specific about the timelines. They also mention sore throat or pain in the throat. And they are more specific about the mouth as well. The Northern Irish guidelines, again, are similar, but their 2 additions are, they mention the importance of a salivary lump, particularly in the parotid and submandibular regions, and again, more detail on timelines. And they also have put in there the importance of earache associated with pain in the head and neck area, which is something that has been associated with certain kinds of ENT cancers. So really comparing the different national guidelines, they are in most respects quite similar, but they have differences in wording, time to trigger red flag symptoms, and there are inclusions of specific scenarios I've covered that are not quite the same in each. They're all valuable to be aware of, even if you work in one area that would be covered by one guideline, to be aware of guidelines in a different country, because that is useful for your clinical practice. So those are the most important things to be aware of, but head and neck cancer is difficult, and I wanted to try and give a few tips for clinical assessment, which I've gleaned by talking to head and neck specialists about how they think about assessing someone. And one of their points is that you can think of head and neck cancers occurring in 5 distinct areas: in the mouth, in the nasopharynx, oropharynx, and the hypopharynx, and the larynx. And each of these has subtle differences in risk factors and characteristic presentations. So with the mouth, the risk factors are poor dentition, bad fitting dentures, chewing of betel nut, tobacco, and HPV, as we've heard. There are some subtle symptoms to be aware of apart from the obvious ones, like an ulcer, leukoplakia, erythroplakia. Poor healing from tooth extraction is a big one. So be careful about people who keep coming back for antibiotics without seeing dentists. Poor healing is an important sign of an oral cancer. Unexplained bleeding in the mouth, bad breath that's new and is a new symptom that hasn't developed, that hasn't been present for a long time. And don't forget sun exposure when assessing somebody who's got something on their lip. Nasopharyngeal cancer is actually a bit apart from some of the other cancers. It's much more common in the Chinese, South Asian, and to some extent Black communities, and it's linked very much to Epstein-Barr virus infection. And it unfortunately usually presents in a quite advanced state, usually with a neck lump rather than nasal symptoms. But think about this one, if people come in with a neck lump, particularly at the back of the neck, and there are associated symptoms around hearing loss, fullness in one ear, perhaps a nosebleed or facial pain or numbness. The oropharynx is the area at the back of the tongue, the soft palate, and the upper throat, including the uvula and tonsils, so the upper part of the back of the throat. And as Kate has mentioned, most of these are associated with HPV infection rather than smoking and alcohol, tend to occur in younger people. So this would be the par excellence difficult one to pick up, in that most of the symptoms people like this present with are common. Look out for people who have persistent symptoms, progressive symptoms, and ones that are unilateral and not bilateral. There are also some subtle changes that can occur, which if you find these with these common symptoms might make you think about that. Because the tumor may affect the back of the tongue and the use of the tongue, people sometimes complain of subtle changes in diction, referred pain to the ear, and some subtle changes in moving their tongue and being able to eat. Now, hyperpharynx, the hyperpharyngeal cancers are further down the throat in the lower pharynx, the piriform fossa, the postcricoid area, and even the upper esophagus. These are very much associated with smoking and alcohol. Because this part of the throat is larger and there's a larger area within the tumor, within which the tumor can grow, unfortunately, these tumors often present late because they've grown large without causing many symptoms. They present with very similar symptoms to the oropharynx, just later. And the big thing here, I would say, is to have a very high index of suspicion in a high-risk person. Somebody who's smoked for a long time presents with quite subtle symptoms. Just think about that. Laryngeal cancers are very much associated with smoking, with hoarseness, throat symptoms, particularly if it's related or associated with referred ear pain on one side, and weight loss. Somebody asked a question about what is hoarseness defined as. Hoarseness is both weakness and change in the voice. So if somebody has difficulty in getting the words out, or they have no problem getting them out, but their voice tone has changed, that would count as a suspicious symptom, particularly in a high-risk person where it's been going on for more than a few weeks. I'm just going to make a quick comment about interpreting thyroid nodules and ultrasound reports. I know that this gives my colleagues quite a lot of grief because we get reports and it's not clear what to do. All reports should now, according to the British Thyroid Association, make it clear if they detect thyroid nodules, into which grade that nodule falls. And there's the U1 to 5 scale that you see there. Anything from U3 or above should be referred. Now, sometimes it's not very clear what it is, and I would suggest, unless you want to just send off a referral, that you go back and ask somebody to make clear what it is in their report. You may get a good answer or you may not, in which case you'll probably refer, but they should report based on this scale. Just going to cover chest x-ray now. We know that if somebody has a persistent cough or somebody has a cough in a high-risk patient, we should do a chest x-ray. Chest x-ray can, of course, cough can also be a symptom of an ENT cancer, not just a lung cancer, as can dysphagia and hoarseness. So consider doing x-rays in all of these situations. And there's a question about what do you do if you've got a chest x-ray that's normal? Do you go to respiratory or ENT? I think what we have to do here is make a judgment based on the symptoms if we have a high suspicion. If you don't feel the chest x-ray is sufficiently reassuring, if the symptoms are too worrying, you need to make a judgment about whether the symptoms are predominantly respiratory or ENT. In Northern Ireland, there are specific red flag criteria for a chest x-ray in people with hoarseness, who've had more than 3 weeks of hoarseness and they're smokers or heavy drinkers. If you have a positive finding, you would then obviously refer on for exclusion of lung cancer. And if there's a negative finding, they specifically suggest you refer to an ENT or a head and neck cancer specialist. Safety netting. The safety netting is important in all aspects of our practice and in detecting cancers, but I think it has a particular importance in cancers like head and neck, where the symptoms are really common, and not all people present with BOND or NICE or other guideline positive symptoms. Sometimes you just need to get them to come back after the requisite time to see if they meet a criteria. So safety netting is very important. And just to reiterate, which I'm sure most colleagues have heard before, the main aspects of doing safety netting well is to check people's understanding, make the advice detailed, perhaps record this properly, give them written advice or text reminders, and encourage them to attend or code these appointments so that they can be followed up electronically. And there are some good examples of paper safety netting advice that can be given, including the one you can see here, which comes from the RCGP. And this will be available with your pack. So I'm going to finish just with some top tips for diagnosing head and neck cancer, which are mainly summaries of what I've said. Presenting symptoms are really common. So look for persistent, progressive, and unilateral symptoms. Look particularly for referred pain, the throat and the ear in a high-risk patient. Look for the more subtle symptoms I mentioned, like changes in diction, swallowing, loss of appetite, or loss of weight. That's not really a subtle symptom. But look for those associated symptoms in high-risk people, particularly if they have more obvious symptoms like throat pain. And good safety netting is often key. Every ENT surgeon I speak to tells me to tell any GP on an education course at this point, bilateral tinnitus and hearing loss are very rarely a sign of head and neck cancer. A lot of people are referred with these, but they are very, very rarely or never really associated with head and neck cancer, except incidentally or coincidentally. And again, heightened suspicion in patients at high risk there's a huge disparity in the importance of common symptoms in people who are at high risk and those who are at low risk. So I'm finished there, Andy.
Lance, thank you. Great topics there. So a couple of questions come through. Unfortunately, we lost Kate. Kate is out in the sticks and her Wi-Fi was broke. So she's relying on Elon Musk's Skylink service and surprisingly has let her down. So I'm going to take over for this last section. I'm just going to go through a few of the questions before I do that. So someone's asking, how long should we wait before referring for a sore throat? Obviously, a good question because we see quite a few people with sore throats that drag on a little bit. The NICE guidance doesn't actually mention sore throat as such, from what I can see for England and Wales, but the Scottish guidance specifies if it's more than 3 weeks. So that seems quite a good guideline to go along. The Northern Ireland guidance says if it's unexplained or persistent, but doesn't give a timescale. So that, I think unexplained, persistent, and lasting more than 3 weeks seems like quite a sensible approach to a sore throat. And obviously, with the risk factors, if someone's got risk factors for head and neck cancer, that's going to make you a bit more suspicious about that, I guess. There's a clinical query, 6-year-old male, large unilateral thyroid nodule, urgent to eat with referral or ultrasound first. I'm reluctant to answer on a very specific patient in that way because there's so many factors to play into that. It depends what you find in examination, for instance. But I think just go with your local pathways for that one, and usually that would be a 2-week wait referral if you were unsure. And again, someone asking a question. Unilateral tonsillectomy, a young patient with intermittent sore throat, if it's concerning. It depends how young they are, I guess, and whether there are any other risk factors for cancer. If it's a child or an adolescent, I would think probably not as serious, not likely to be cancer in those scenarios. More questions coming in here. We're going to have to come back to these because, as I say, Kate is actually unable to log back in. So I'm going to actually take over now. And then if Kate is able to get back on, she'll come to some of your questions that are coming through now, because obviously I won't be able to answer those. And Lance, if you're able to answer any, have a go if you can. Lance hasn't done the Q&A before, so that'll be a new experience for him. But I'll carry on with the presentation in the hope that Kate is able to join us. So we're going to talk about inequalities in head and neck cancer now, which is, as I mentioned before, is something I feel quite passionate about, actually dealing with inequalities in my daily work all the time. And one of the main causes for inequalities is actually this what we call the appraisal interval, and that's lots of patients have symptoms of head and neck cancer which are actually pretty, in most cases actually are quite benign. So we're sore throats, cough, a bit of a hoarse voice. There are so lots of benign conditions, and patients obviously think, oh, actually this is nothing to worry about. And head and neck cancers only account for about 3% of all new cancer cases in the UK. And although those numbers are increasing, that's a relatively small amount of cases. So people might not know people who've been through it and might not know the symptoms and things they need to look out for. So they're less likely to seek help. And that also has an effect on us. We don't see a lot of these cancers in our clinical practice, so we might not be prepped to refer these patients as quickly or diagnose these patients as quickly as we might for other cancers. And this appraisal interval, this is the time when someone actually notices that they have some symptoms and then decides to do something about it. So they're in a sort of wondering what it could be. They're not actually at the point where they need to decide to see a clinician. They're just trying to weigh up their options, think what's going on. As I say, the fact that a lot of these symptoms are often benign means that can drag on a little bit. And then they move into that sort of help-seeking behaviour a bit later than they might do for other ones. And this was seen as a common barrier, denial of severity of symptoms, so it's stopping people actually seeking help. There's not a lot of evidence around which particular demographic groups are most likely to be affected by that, but it's probably likely to be in areas of deprivation. And the other thing is there's a barrier to access to get to see us. As we know, it's difficult to get an appointment to see a GP for all sorts of reasons. But the people who are most likely to need that access, the people who are most likely to get head and neck cancers, are probably the ones who are going to find it the hardest to access healthcare. People with lower health literacy, for instance, people in areas of higher deprivation, people who don't speak English as their first language, and who struggle with digital technology and maybe booking online appointments is something that they struggle to do. And there are lots of resources to help with that. Doctors of the World have got a great set of leaflets in different languages that explains how the NHS works to people who don't speak English or are maybe new to the country, and that can be helpful and teach them how to access healthcare effectively. And so what we should be doing as GPs, if we can, is to try and think how can we change our practice to make it easier for people in these groups to access healthcare, to access appointments and get those early appointments that they need. Can we think about different types of appointments? If someone is unable to cope with online appointments or telephone appointments, can we record that in their notes so that people are able to offer something else if they try to make an appointment? Sending text reminders of an appointment that has been booked, being a little bit flexible about appointment duration, for instance, or if someone turns up a bit late or is struggling to get to surgery. And then if you do see someone who is in a high-risk group, just proactively asking them about some of those non-specific symptoms that might indicate oral head and neck cancers. Now, dentists have a key role to play in this, and as we know that it's difficult to get an appointment with a GP. Try getting an appointment with a dentist, even more difficult in a lot of areas. And there are these dental deserts, particularly again in areas of the most deprivation where people are the highest need. And that sort of takes away an opportunity for early detection of head and neck cancers. It's often dentists who'll pick up some of these key symptoms or signs when people come to see them. And inability to afford dental services is something that puts a lot of people off. It is quite expensive if you're not entitled to NHS dental treatment. And the groups that are least likely to seek dental care as a result of that, men generally, but those particularly from the most deprived groups, the ones who are most at risk of developing those head and neck cancers. And there's a recent report looking into this. It's fairly damning, really. And it was pledged that the government were going to try and make dentistry more accessible in the NHS and available to all who need it. But there's actually no date being set to that. There's no apparent urgency in making this happen. And actually, if you understand that actually more people die of mouth cancer than they do of road collisions, road crashes in the UK nations, that puts it in perspective, really. You think about the amount of effort that goes in trying to prevent people having accidents, whereas you can't get an appointment with a dentist very easily, and it just needs investment, doesn't it? It just needs a change to improve that access. There was a point to consider about a dentist cross referrals, and someone mentioned in one of the questions before I came over about can dentists refer direct to hospitals? Yes, they can. They can refer suspected cancer cases to hospital. Actually, and some of the guidance, some of the NICE guidance actually recommend that if we do suspect something, we see a patient that we want to, that has a suspicious lesion in some areas, we can actually we should be sending into a dentist to check that out. Now that is potentially a problem, because it's going to obviously put a delay into the referral, particularly if the patient is struggling to find a dentist who will see them. And so we do need to think carefully about that if we're going to do that. It could delay, it can cause confusion for patients. May think, no, I can't be bothered with that, it's not that serious, I'll leave it. And this late presentation may be caused by that, particularly if someone's having to take time off work, for instance, to get an appointment to see the dentist. So what they're thinking about, do we need to maybe seeking advice and guidance from dentists? Only really if there's a diagnostic uncertainty, if we're not sure what's going on, and there'll be some guidance in the resources to help you in deciding on what the best way to use dentists, if you are going to use them at all. And if you go on YouTube, actually, there's a really good little video. I found it the other day. If you just type in taking a photograph of an oral lesion with a phone, there's a nice little video being produced, I think, at one of the universities up north. Shows you how to get a really clear photograph of oral lesions that you can then presumably send to the hospital for advice and guidance if you're not sure. And this Doctors Net toolkit that CR UK have been working on, that's going to be launched fairly soon in the spring. It's going to be free to access, although you will need to register with Doctors Net to use it. I guess most of you already are. It's been expanded, it's been refreshed. There's some nice videos, and you can see little clips from the videos to the right of the screen there, which will show you how to do a good examination of the mouth and looking for signs of oral cancer. And there'll be links to that within the raw resources, which you can access through the tabs. Some more resources that you can get from CR UK. Some information about safety netting and the key points that you need to communicate to patients when you're doing this. There's some actions for us to carry out as primary care professionals as well, and some things that GP practices can do to try and increase access, easy access to healthcare, and try and break this sort of barrier that's in the way of people seeking help and getting their diagnosis early. So that was a very quick rattle. I'm going to try and work through some of these questions if Lance has not been able to answer some of these. Let's have a look. Now, this is on the hoof a little bit. So is it better to send to advice and guidance to MaxFax instead of a dentist? Actually, yeah, it depends on your local services. And I think if you've got a friendly MaxFax department who are willing to access advice and guidance and maybe look at a photograph if you manage to take a decent one with your phone camera, actually that might be a quicker way of getting a decision than someone having to go out seeking for a dentist, for instance. So that sounds quite a good idea. I think, again, we're all very pragmatic, aren't we? And we tend to do what's best for the patient. Sometimes the guidelines can limit that a little bit. That's true. We'll come back to the patient with the unilateral tonsil enlargement. Is 19 years old. I suspect that isn't any cancer. But again, if it was persistent and you weren't sure what it is, I'd be considering other diagnoses. I did see someone with a lymphoma, I think, that presented with a large tonsil for quite a long time. So I think you might want to get an advice and guidance on that patient if this tonsil enlargement is persisting. NICE says dentist needs to refer as 2-week wait for erythroplakia, leukoplakia. Can we refer directly if the dentist is not happy to do so? Yes, I would say be pragmatic about it. If you're confident in that diagnosis and the patient is unable to get a dental appointment or access a dentist, then definitely I would say do that referral yourself. We don't want these patients to fall through the cracks. So if you're able to do that, I think that would be a good idea. Someone here, what is it about poor dentition that increases the mouse cancer risk? I think if someone's got a sharp tooth or something that's rubbing on the tongue, that constant inflammation can then lead on to problems with oral cancer. I think that's most of the questions that have come in. I'm going to see, Lance, have you got? Was there any questions that you've answered that I've not mentioned that you want to come to over there, Lance? I'll mute myself so you can speak if you want to.
I think somebody asked a question about children, the risk in children. Fortunately, it's very rare. The main cancers that do occur in children, and the very unfortunate children, are usually lymphomas, not Hodgkin's or Hodgkin's lymphomas, and occasionally sarcomas. And you would expect them to present with a lump, similar to most childhood cancers, but they are very rare. The other thing about poor dentition is that it leads to bacterial overgrowth. And some of these bacteria are thought to be part of the reason why these people are predisposed to cancer, because they have a carcinogenic effect. I think there's quite a lot of information or evidence now that bacterial overgrowth in the mouth is bad for you, including for dementia. So I think those were the main ones, Andy. The role of radiation, I suppose that's also the effect of radiation on carcinogenesis in the mouth, particularly very rapidly reproducing cells, as you do have in the oral cavity, is at high risk.
Thanks, Lance. It's great to have your expertise here to step in there and bail me out a little bit. I struggle with doing two jobs as I can. I did have loads of really good resources lined up to share with you in the Q&A if I was doing that for the whole of the session. But what I'll do is after the talk has finished, I'll carry on answering some of those questions into the Q&A here. And if you come back to look at the recording of the webinar, you will then see those resources appear within that. And there's a load more questions coming in now. So I'll probably have a look at some of those at the end of the talk. And so if you come back tomorrow and look at the recording, you should be able to see the answer of that. Just mention a couple of things. If someone is really struggling with the costs of healthcare, there is a form you can fill in called a HC1 form, which then can entitle them to free dental care. So if you know someone who's in deprivation, you can recommend that as well. And that includes people on benefits, for instance, that can access that. So I will put a link to that form in there, because it's something I use a lot in my practice, and it does make a big difference if someone suddenly is able to access these things for free. I think that's the end of the presentation for this evening. I say I will come back to some of the questions that have been posted after the talk is finished, and you will be able to access those on the on-demand tomorrow. I think you've done the questionnaire. And thank you very much for joining us this evening. And it's been great. There's been so many questions for such a short presentation. Thank you, Lance, for his expertise, and for CR UK for how they've helped us to pull together this really excellent talk. And thank you to Kate, who sadly disappeared. And I will thanks for joining us, and keep up the good work.